So good morning, everybody. Welcome to this 70 lecture series at the FM Kirby Center at Johns Hopkins and Kennedy Krieger Institute. So this month, we are delighted to have our speaker, Dr. Irene Wang from Cleveland Clinic. Dr. Wang got her bachelor's degree from Zhejiang University of Biomedical Engineering. For people who are not from China, this is one of the best university in the country and also one of the top, if not number one, BME Biomedical Engineering program in the country. And then she got her Ph.D. training at Case Western Reserve University, also in biomedical engineering. So after that, she moved to Cleveland Clinic, where she started to work with people like Ahmed and many other people. So I let Ahmed talk about her work at Cleveland Clinic, and after that we can go to the talk. Ahmed.
Thanks, June, for the introduction, and thanks, Irene, for being here today. We look very much forward to this lecture. So Irene, now I know her from a few years back, 2012 to be more specific, where she took me as a resident in child neurology at the Cleveland Clinic and helped me and was very generous to incorporate my efforts into some of her research projects. She has grown so much since then, and she is now the director of research and a scientist at the Epilepsy Center at the Cleveland Clinic, one of the most proeminent epilepsy surgery centers in the world altogether, and is an associate professor of neurology at the Cleveland Clinic Lerner College of Medicine. And she is going to teach us today about the application of 7 Tesla MRI in pre-surgical evaluations for patients with refractory epilepsy. And just to put it in perspective, Cleveland Clinic has some of the most outstanding numbers in terms of volume, quantity, quality when it comes to 7T MRI application in epilepsy. So without further ado, Irene, we look forward to your talk today.
Thank you so much, Ahmed, and thank you, Jin. What a wonderful introduction. It's my pleasure and honor to be here to speak with you and the audience today. So I'm a very epilepsy imaging focused person. So today we're going to only talk about the use of 7T MRI for epilepsy pre-surgical evaluation, sharing with you our experience doing more than 160 scans, some of the knowledge that we would like to share with you. As Ahmed mentioned, I'm embedded in a very busy epilepsy center with a large patient volume. Patients undergo pre-surgical evaluation for their epilepsy surgery. These patients are typically very pharmacoresistant. They are at the stage that a brain surgery would be sort of their final hope for cure. And for these patients, finding an MRI lesion on their MRI is of crucial importance for the outcome of the pre-surgical evaluation. So there is a prior study showing that if you find a lesion on the MRI versus if there's no lesion on the MRI, the lesional patients are 2.5 times more likely to become seizure-free than patients who have no lesion on the MRI. So this business we're doing with 7 Tesla to help lesion detection makes a huge difference in the outcome of pre-surgical evaluation. So one of the million-dollar questions we're asking is, which specific group of epilepsy patients would 7T benefit? And we will share some knowledge from our paper focusing on 3T non-lesional group and 3T lesional group. We'll talk about specific pathology subgroups. We'll talk about some of the weakness areas that 7T has in terms of epilepsy imaging. And I would love to hear what you guys think when you practice 7T with the epilepsy patients. We performed a consensus review study with 7 neuroradiologists, and I'll share some findings from the study about how they think as a group. And lastly, I will share a exciting research project that we did on 70 imaging pathology electrophysiological correlation study on this 70 sign called the black line sign. This is the outline of the talk today. So I think for those of you in the audience, you're very familiar with the device timeline of 70. In 2017, 70 was FDA approved for official diagnostic use. And there has been a few 70 studies in the literature of epilepsy presurgical evaluation. This is a big study. This is a retrospective review study, sort of meta-analysis, looking at 21 centers data, more than 2,000 70 MRI scans. And this was published on Neurology just a couple of years ago. And we contribute a lot of data to this meta-analysis. There are a lot of scans that were done before the FDA approval. And in that setting, patient scanning is performed with local IRB approved research. And in today's talk, I will talk about data from 2014 to 2019. At the Cleveland Clinic, this is the time period that we were using the pre-FDA approved model, the Siemens Magnetum. We upgraded to the FDA approved model in 2020. But all these data that we published were performed on the scans were performed on the pre-FDA approved 70 scanner. Specifically, we'll talk about the numbers, about 160 for patients and 50 normal controls that we used for post-processing studies. When we refer patients with epilepsy to 70 scanning, we have more stringent safety screening. Their epilepsy patients frequently have metal devices. Some devices such as VNS and RNS may be 3T compatible, but they may not be cleared for 70 safety. So unfortunately, we do not include those patients in our study. We have an excellent team of MR physicists who are always available to help to assess safety margins when we come across surgical plates, dental implants, tattoos in our patients. For pediatric patients, we have a low body weight threshold of 30 kilograms to have safety, to have safe scanning using 70. Other common contraindications are fairly similar to a 3T. One thing we always stress to patients is that they need to be, really pay attention to not move in the scanner, because 70 is more sensitive to patient motion. If we see a patient several 3T scans earlier were motion corrupted, we likely will not refer the patient for a 70 MRI. And this is also related to our center setup. Our 70 scanner is at a separate building from our main campus, so we cannot perform anesthesia on all our 70 scans. They are all performed as outpatient studies. So motion is a big contraindication too. So why is more Tesla better? More Tesla results in more signals from photons, and we can use these signals to either increase the SNR, make the scan faster, make the voxels smaller, and all these are very beneficial to epilepsy scans. This is a comparison of our 70 protocol to our 3T clinical protocol. And for the data that we show, that I will show in the rest of the talk, this is the imaging parameters that we used for the 70 scans. And as you can see, comparing to the 3T, all of the sequences were sub-millimeter, have sub-millimeter implant resolution and smaller slice thickness. So our rationale is that since 7T MRI offers increased signal to noise and contrast to noise ratio, these may both improve the detection and visualization of cortical malformations, particularly focal cortical dysplasia. And we designed this study to assess the clinical value of structural 7T MRI and its post-processing for the non-invasive identification of epileptic brain lesions. So for the scope of the talk today, I'm only going to talk about structural part of the 7T MRI and its post-processing. I think Dr. Stephen Jones, a couple of months ago, he gave a talk at your seminar, and he might have shown some very interesting data on resting state or functional 7T MRI. So for today, we're going to focus on the very practical part of lesion detection yield of structural MRI and its post-processing. So this study that I'm showing you has already been published a couple of years ago. And to date, it's still the largest to date cohort of epilepsy patients with a non-lesional 3T MRI and the lesional 3T MRI. We look at them separately. Some of the key addition to literature include we look at these findings in terms of their correlation with intracranial EEG, histopathology, and seizure outcome. And in addition to visual review of the 7T MRI, we use post-processing to enhance the visual review yield. So this is sort of our workflow here. We included 5 years worth of data. We divide the patient into two groups, a 3T non-lesional group and 3T lesional group. And this is our famous Dr. Stephen Jones, who gave a talk a couple months earlier. He was the lead neuroradiologist who collaborated with me on all the 7T epilepsy studies that you will see today. So Dr. Jones spent a lot of time and energy and patience with me to review all the 7T scans. And remember, this is still 7T in the pre-FDA approval research phase. So the 7Ts were reviewed in comparison to a 3T. And if there is additional finding, we communicate the finding to the epileptologist that's in charge of the patient or the patient management conference team. And this is all under IRB approved research where we can communicate the additional findings. We then, the patient then, with this information, the patient undergo intracranial EEG or resective surgery. This is all done after PMC consensus in context with all the other pre-surgical evaluation data. Surgery is performed, and then we assess the clinical significance of the 7T findings, which was identified at this stage. We compare them with intracranial EEG ictal onset, seizure outcomes, and histopathology. So you've seen the slide earlier. This is the 7T protocol that was used. In addition to performing the scan, we post-process the scan. And we, as input image, we use the Uniden image from the 3T T1 weighted MP2 range, which was served as input to the MAP or morphometric analysis program. This is a voxel-based morphometric processing program that helps us identify subtle lesions in the brain, particularly subtle FCD lesions. And we compare the patient's brain to a group of normal controls. So this is a feature map that's generated from the patient's 7T T1 weighted image. This particular feature is called gray-white junction blurring. It depicts the blurring between gray matter and white matter. As those of you in the audience who are familiar with the focal cortical dysplasia, a main pathology for epilepsy, this pathology is oftentimes characterized by a blurring in the gray-white matter junction. So we calculate that feature map based on the patient's individual scan. And this is a average normal control scan from 50 healthy controls. We take the difference between these and we divide it by the standard deviation of the normal control database. So this gives us a Z-score map that tells us how likely that blurring in the gray-white junction exists in the brain. So this normalization process is very necessary to get rid of the normal variance in the brain so that we have fewer false positive findings. So guided by this, these bright spots on the Z-score map, we go back to the original 7T MRI and we look at different sequences, different views, and the radiologist, Dr. Jones, makes the call whether this MAP-guided lesion is actually a legit lesion. We used a 5-point scale system to sort of mark the confidence of the radiologist about the lesion. And anything that's 3, 4, and 5 on this higher end of the scale, we consider them as a likely lesion. The efficacy of MAP post-processing to guide subtle FCD detection has been previously demonstrated with the 1.5T and 3T studies, and many of these studies were performed from our group. So that serves as the rationale that if we have better input to these algorithms, we're gonna have better output in terms of sensitivity. Okay, so let's look at our 3T non-lesional group. We have 67 patients whose 3T were officially read as non-lesional on the official radiology report. By visual inspection of the 7T in these epilepsy patients, we get 22% of extra lesions. So this lesion yield, visual review yield, is on par with what's reported in the literature by these studies. So once you see it on the 7T, if you look back at the 3T, you can see those lesions in most of the cases. And in fact, in 80% of these cases, the lesion, once you see it, it's hard to unsee it. You can see it on 3T, but the lesions are often with less conspicuity. That's why they were not picked up at 3T. Now, de novo lesions were, those are the lesions that were seen on 7T, but not appreciated at all on 3T. This occurred in 20% of the cases. And this is typically because the lesions were very, very small and they were caught in 2 imaging slices. And so that's why they were not seen at all. Now, what I find to be interesting and encouraging from our data is that if we add MAP post-processing on top of the 7T to guide the visual review, we can almost double the yield to 43%, and that's a pretty high yield. We looked at how relevant the 7T identified lesions were by looking at their correspondence with the ictal onset of intracranial EEG. We found that in 81% of the 7T identified lesions, the location was either identical to or contained within the ictal onset on the intracranial EEG. This means that they are highly relevant to the epilepsy. And looking at the resection and outcome, complete resection of the 7T identified lesion was significantly associated with seizure freedom. And this is what the data looks like. When the 7T was negative, the seizure-free and not seizure-free were almost half and half. Another interesting finding is that our data showed patients with a positive 7T MRI was significantly more likely to undergo surgery. So this is how the data tabulates. So this suggests that having a positive 7T MRI may be a positive indicator for a successful pre-surgical evaluation. This could be particularly useful to know when the patient's 3T MRI is negative already. So I'm going to show you a few examples with some pretty pictures here. This is a patient with a depth of sulcus. This is the depth of the central sulcus, and this area is the substantial gyrus. On 3T, although I put a little arrow there, on 3T, this lesion was missed many, many times, maybe 6 or 7 previously performed. 3T epilepsy protocol MRI. And on 7T, this lesion was conspicuously picked up by the 7T MAP and confirmed on the T1 weighted sequence. And this is a zooming of the T2 star sequence depicting the gray white indistinction. We did a mini SEEG for this patient with just a few electrodes. The dots here are telling you about the sagittal view of how the electrode trajectories go into the brain. And the red electrode is where seizures are coming from. And as you can see, it's exactly at that subtle depth of sulcus lesion. This is the postoperative MRI telling us how focal that resection is. This is what an actual SEEG data looks like. On the seizure onset is at electrodes R5 to 8. This is the R electrode, and this is where the seizures are coming from. And just a few seconds later, it spreads to brain structures in the vicinity in the Q electrode. So I always thought if we don't have imaging guidance to identify the location of this lesion ahead of time, we will probably need more electrodes to fully sample that epileptic network, or we may simply miss it. And this just speaks to the important role of 7T MRI to guide or optimize the SEEG implantation planning. This is another patient where 3T, although I put an arrow there, you may not be so convinced if there is anything there. But on 7T, guided by the MAP, it's very hard to miss that bright blob on the gray-white junction Z-score map. You see, there is a depth of sulcus, very subtle transmental sign, which is very hard to see on the 3T, but you can clearly see it on the 7T. On the sagittal view, you can see the subtle blurring in the parietal operculum region. And again, we devised a SEEG implantation guided by that finding. And that red electrode, single red electrode, is where the seizure onset is. The patient underwent a very focal resection in this area. Type 2B FCD was confirmed in the surgical pathology, and the patient became seizure-free for many years after the surgery. This is an example of another type of FCD, FCD2A. 3T image here, and on 7T, again, big blob on the 7T MAP telling us to look back at that region. The 7T T2 star image help zoom in, perhaps help us better appreciate the blurring in that region. This is the SEEG implantation. Only the electrodes, there were way more electrodes than just these 4, but only these 4 were in plane with the lesion. And this is the red electrodes are the seizure onset zone on the SEEG. They are consistent amongst all the seizures that we captured during the monitoring. And as you can see, the location is very much concordant with the location of the subtle lesion. Resection happens here, and this is a pathology slide this is the slide, and this is a zoomed in slide that showed the accumulation of dysmorphic neuron. These are, there are these large neurons here with bizarre shape. They are the underlying pathology. They are the hallmark of FCD type 2A. Very interestingly, there is this new type of pathology called MOGI. This is a long name. This is a new type of mild malformation of cortical development that was recently proposed in the field of epilepsy. And this pathology is characterized by an increased oligodendral cell in the white matter and at the gray-white boundary. And this is what this oligo-2 staining is showing us. So we found 7T to contribute to the imaging of this pathology very much. 7T benefits a lot because the increased gray-white boundary, and particularly equipped by the 7T MAP, you can just depict that blurring that happens on the pathological level. You can, this reflects on the imaging level at 7T very much so. And we consistently saw this in quite a few of our MOGI cases in our series. Okay, so we got asked this question a lot. You can do MAP on 7T, you can do MAP on 3T. How do these compare? So in the 24 7T MAP positive cases, we looked at their 3T MAP finding. In 25%, so 1/4 of these cases, 3T MAP was actually negative. And we looked very carefully at the same area of the lesional area. On 3T, the Z-scores are typically low, or sometimes there are artifacts at 3T. It just so happens there are artifacts at 3T preventing those lesions to be detected. In 46%, so about half, the 7T MAP delineated abnormality had improved conspicuity. So this includes a clearer connection to the cortex. I will show you some pictures later. And larger extent of abnormal cortical lesions. I will also show you a case later. In about 30% of the cases, 7T MAP and 3T MAP were similar. So there's indeed some additional yield of doing MAP on the 7T as illustrated by this bulk of data. Okay, as promised, this is a case that shows you a comparison between 3T MAP for this frontal lobe FCD. And this is the corresponding 7T data. And as you can see, especially on the 7T MAP, you can see this lesion beautifully delineated, connecting the gray matter into the white matter and through the ventricle. This beautiful delineation of the transmental sign just makes the abnormality so much more confidently detected as you just look as compared to the 3T imaging. This is another case of a type 2B FCD in the superior parietal lobule. This is a 3T image on the left, 3T MAP on the right. And in comparison, this is the 7T image. If you compare the 7T with the 3T raw image, you can already see there is a larger extent of abnormal cortex, and the extent on the Z-score map also confirms that. So to conclude this part of the study, our data showed that 7T may detect previously unseen subtle FCD in almost 50% of patients with non-lesional 3T MRI. And the MRI post-processing based on 7T significantly increases the yield for FCD detection. And when the 70 finding is concordant with the electro-clinical profile, these additional findings should be targeted by intracranial EEG or surgery. Okay, so what about cases that 3T is already lesional? Would 70 benefit these cases? In our series, we have 47 patients with 3T lesional scans. And this is a mixed cohort with hippocampal sclerosis, focal cortical dysplasia, tumor, cavernous malformation, periventricular nodular heterotopia, and polymicrogyria. For those of you who are relatively unfamiliar with this pathology, I have plenty of pictures coming up. So fairly mixed cohort. In 28% of these patients, 70 had additional finding. And what are these findings? These findings in 19%, these findings are additional smaller abnormality seen either ipsilaterally or contralaterally in the cases with periventricular nodular heterotopia and polymicrogyria. In a couple of cases, 70 could not redemonstrate the 3T lesions. And the intracranial EEG and surgery results are consistent with 70, not 3T. So this means that the 3T lesions are probably fake outs. In one patient, FCD was detected as dual pathology when when hippocampal sclerosis was already detected on 3T. And in one patient, I think I have a picture coming up, 70 helped clarify the nature of the lesion. So this is a case with periventricular nodular heterotopia. The nodules, this is a coronal zoom in of the occipital region. The nodules were missed on the 3T. They were not pointed out at all. But on the 70, you can clearly see the existence of the presence of the lesions. This is a case where 70 helped clarify the nature of the lesion. On 3T, this patient had this suspicious lesion, mostly in the white matter, but with some suspicious, unclear, questionable connection to the gray matter. Now, clarifying the nature of this lesion makes a huge difference in this patient's care because everything else, EEG, MEG, points to the same side, but more posteriorly. So if this lesion is a real lesion, things get more complicated. If this lesion is just a non-specific white matter change, then we can leave it alone. Now we imaged the patient at 70, and 70 clearly demonstrate that this is a white matter lesion. There's no connection to the cortex, and this is perhaps just a non-specific ischemic change. And we did leave the patient, leave that area of the brain alone. In our cohort of these 47 patients with 3T lesional, in whom 3T is already lesional, we found that patients with single focal lesions typically undergo surgery without intracranial EEG or stereo EEG, SEEG. And this is not surprising because that's how the practice is. In 16 patients, they have more widespread or multifocal lesions, and they are typically the periventricular nodular heterotopia lesions, polymicrogyria, cortical infarct, tubers, cysts, and cavernous malformation. And these patients typically underwent intracranial EEG. 75% of them did. And we compared the 70 findings with the findings from the intracranial EEG. In 4 patients, the concordance was, we call it concordant plus, meaning the lesion extent is greater than the ictal onset on the SEG. In 5 patients, the lesion extent and ictal onset on the SEG partially overlap. And in 3 patients, they're discordant. So lesion is one area, SEG onset somewhere else. And there is a case with cysts. There is a case with developmental venous anomaly, and there's a case with polymicrogyria. With cyst and DVA, it's not so surprising because we know these lesions usually do not contribute to epilepsy. With polymicrogyria, this is quite interesting. There is actually a recent study published by a French group looking at the epileptogenicity of polymicrogyria as a pathology entity. And they showed that not all of these lesions are epileptogenic. So here we kind of have some support on the varying epileptogenicity of these types of lesion from our 7T data. In these patients, when we look at their surgical strategy, it largely depends or is largely based on the intracranial EEG results, not on the extent of the MRI abnormalities. This makes sense because as we look at the concordance data, not all of the MRI abnormalities are epileptogenic. While we show from the data that the additional 7T finding may not necessarily be epileptogenic, we still think it's useful to know the full extent of lesions to contribute to a good electro-clinical hypothesis for intracranial EEG planning. So to conclude this part of the talk, for patients with already lesional 3T MRI scans, 7T may better elucidate the extent of multifocal abnormalities and pathologies such as periventricular nodular heterotopia and polymicrogyria. These are the pathology subgroups that may benefit more. And we can use these additional findings as potential targets to improve the accuracy of intracranial EEG implantation. Now, what do the neuroradiologists think as a group? We did a consensus study using the 47 epileptic lesions in the already 3T lesional group. Again, this was led by our neuroradiologist, Dr. Stephen Jones. We denote those lesions with an arrow and save the image as a key image into the PACS system. This was all done meticulously by Dr. Jones. And guided by these arrows, the lesions were reviewed by 7 different neuroradiologists. So note that we did not ask the radiologists to search the whole brain for these lesions. They were guided by this arrow to specifically evaluate that area of the brain. And this was done because we couldn't, this is a lot of work. 47 scans, different areas to rate, 7 radiologists. It's not so feasible for us to ask everybody to do whole brain lesion searching. So we asked them to do a focused review. We then compare the assessment of imaging characteristics, lesion presence, conspicuity, boundary, and the existence of artifacts. And we did the statistical testing for their agreement. So this is for one particular case, what the data might look like. In this case, we have this subtle depth of sulcus FCD lesion, and we have a reviewer 1, 2, 3, 3 reviewer 7, and we asked the reviewers to separately rate the lesion presence on 3T and 7T, compare the lesion conspicuity from 3T to 7T, and lesion boundary, again, separately on 3T and 7T. So putting all these data together, we try to assess how the radiologists think as a team for the improvements, if any, with the 7T data. So the first finding that we show with our data is that the presence or the diagnosis of already demarked lesions was not different between 3T and 7T. And this makes sense because these were already lesional we put an arrow to ask the radiologist to confirm if the lesion was there. They typically confirm, so 3T, 7T impression, not that different. However, what was different was the lesion conspicuity, which was significantly increased at 7T for the overall group of 47 patients, and in specific pathology groups such as FCD, nodules, and polymicrogyria. The lesion border increased, the demarcation of lesion border increased significantly at 7T, again for the overall group, for nodules, for tumor, and for polymicrogyria. We looked at the kappa agreement data amongst 7 radiologists. They don't usually agree, and the agreement data are all in the fair range, which is also not that surprising because remember we did this study in the earlier phase of the 7T technology being adopted for clinical use. And the paper was published in 2021, but the data was reviewed a few years before that. And there's quite a bit of learning curve as some of our radiologist colleagues, such as Dr. Jones, they are the pioneer of 7T imaging, but others may be relatively unfamiliar with how the images look. So this learning curve is not small, and it may contribute to the fair range of the kappa agreement data. So some pretty images coming. This is a case with FCD lesion with the same lesion presence, but improved lesion conspicuity and lesion border. This is 3T data, and this is 7T data showing a much improved, much clearer lesion and much better delineated lesion border, as agreed by the group. This is another case with the periventricular nodular heterotopia. This is the same patient. This is a very extensive lesion, axial, zoomed in coronal, and sagittal view. These are the 3T data. And on 7T, you can just see how much more conspicuous the lesions are. And you can sort of see the internal inhomogeneous components of the lesion, which is intriguing. And lesion border was also felt to be more clear. This is a patient with extensive polymicrogyria, 3T image here and 7T image on the right. The lesion was there, no question. The presence did not change. But what was felt to be improved is the conspicuity and the border, especially if you look at this more posterior area in the temporal occipital region. Now, what are some of the weak points shown by our data? We showed that artifacts affected lesion conspicuity in about 30% of the patients at 7T versus about 5% at 3T. So there are more artifacts on the 7T scans preventing the assessment of lesion conspicuity. And this is typically due to susceptibility, motion, and pulsation. And this is an example, again, 3T on the left and 7T on the right. This is the type 2B focal cortical dysplasia located at the temporal pole, the really tip inferior part of the temporal pole. And the susceptibility artifact on the 7T just prevent from, makes the lesion conspicuity much worse than 3T. So in our cohort, we showed the weak spots are the inferior temporal pole, collateral sulcus and orbital frontal. And actually, in our practice now, if patients have very focal hypothesis, if our surgical hypothesis is very focal in this area, we typically do not refer the patient to get an additional 7T scan. Well, having said that, this data is a few years back, and this is clinical imaging. There are many studies, very exciting studies with advanced pulse sequence design compared with the PTX system, which may help alleviate these artifacts in the near future for clinical imaging. So to conclude this part, our competitive assessment from the neuroradiologist team showed that patients with focal cortical dysplasia, periventricular nodular heterotopia, and polymicrogyria would likely benefit the most from 7T due to improved lesion conspicuity and boundary. And the weak area is in the anterior inferior temporal regions. There are temporal lobe is a big area of hit by in patients with epilepsy. If patients strictly have pathological findings that you are suspecting in these regions, they are likely they are less likely to benefit from 7T due to artifacts. And future technical development may likely elevate the performance of 7T. Okay, so venturing into research with the increased capacity of 7T to examine pathologies in a very fine, at a very fine level, we can do many very cool things. So today I want to tell you a little bit about our study to look into this sign called black line sign. This is a sign that's best seen on T2 star weighted sequence on 7T. It was originally first proposed by the Italian group in 2019. And it's defined by a intracortical hypointense band located in the deep layers beneath the seemingly preserved upper cortical mantle. Okay, so in their study, they proposed that this could be an imaging marker for FCD type 2B. And as they show in their relatively small patient cohort. So I know I read the definition to you, but nothing beats a picture. So this is a zoom in of this coronal slide on the left on the T2 star weighted sequence. What we see here is a depth of sulcus type 2B dysplasia. Of course, you see the subtle transmental sign. And observing the internal structure within the gray matter, you would see normal gray matter, and you would enter this area of almost like a double track. So the integrity of the gray matter is seemingly preserved, but there is this hypointense band within the gray matter. Now, one immediate question that comes to mind, it came to my mind and Steve's mind, and maybe many of you may be thinking, this could be just a subcortical U fiber, right? So is this the lesional component, or is this the white matter component? We designed our study to specifically look at what this means. We went back at our 7T cohort who had histopathologically confirmed FCD2B. And we try to show how often does this sign occur. We try to look at the correspondence of this sign with the intracranial EEG atrial onset. And we try to answer the question, is this a subcortical U fiber? Is this gray matter finding or white matter finding? There are a couple of ways that we can do it. We attack the problem with two arms. One arm is the quantitative MRI analysis on the 70T1 map. So this is the T1 quantitative map that's generated from the MP2 range that gives you the quantitative T1 value. And we also performed in cases that we have well-matched MRI pathology slices. We also specifically compared the pathological underpinning of this black line sign. This study was led by our excellent research fellow, Dr. Ying Tang, who went through our retrospective data and included all patients with type 2B FCD. In our 70 cohort, we have 14 patients with histopathologically confirmed 2B. And then out of these 14 patients, 12 patients out of the 14 had a visible black line sign. So we did quantitative analysis, quantitative MRI analysis on the T1 map on 70, and we used meticulously delineated ROIs to compare the black line region to the gray matter and white matter near the lesion, away from the lesion on the ipsilateral side and contralateral side. So I'll show you some of the data later. And the other arm, we looked at we reconstructed the 70 the images with the 70 black line, and we looked at their correspondence with the intracranial EEG data by co-registration of these data. When postoperative MRI is available, we co-registered postoperative MRI to look at the association between the removal of the black line sign and seizure outcomes. And we looked at all our pathology slides, and there's one case that we have almost perfect MRI pathology alignment. And that one case is actually, it's very precious data because remember, this is all done in a retrospective fashion. So you almost have to be lucky to have a slice that's cut in exactly the same imaging slice where the black line sign is most conspicuous. So we do have that one data. We took advantage of that precious data, and we looked at the histopathological underpinning. So as I mentioned, the black line sign existed in the vast majority of pathology-proven FCD type 2B in more than 85% of these patients. And out of the 7 patients with intracranial EEG data, the black line sign showed in 5 patients, the black line region was completely overlapping with seizure onset zone, and in 2 patients, partial overlapping with the seizure onset zone. So this means the black line sign is directly related to epileptogenicity. When the black line region was completely included in the resection, patients were more likely to become seizure-free, again, confirming its epileptogenicity. So these data may suggest that the black line sign is a microstructure within the FCD type 2B lesion, which we may help leverage the presence of the sign to better detect, delineate, and subtype FCD type 2B lesions. Here are some examples that we published in the study. This was on neurology a couple of years ago. This is a big region with the type 2B FCD, and the black line sign was seen very well on multiple slices in on axial and coronal view also. This patient actually had a prior anterior temporal lobectomy from an outside institution. Seizures recurred, and the patient came to Cleveland Clinic for reevaluation. We delineate the full extent of the lesion. The patient underwent a bigger resection, which included the black line region and became seizure-free after the resection. This is another case where we identified a subtle black line sign in the frontal parietal perculum region. You see the black line sign is around the sulcus here. And the ictal onset is delineated R5 to R7, which just goes right through the black line sign. And the black line region was indeed included in the post-operative MRI, showing it's completely resected, leading to sustained seizure freedom. So by our quantitative MRI analysis, as I mentioned to you, we meticulously delineated ROIs for the black line sign, for the entire lesion, gray matter, for the ipsilateral normal gray matter 2 gyri away, contralateral normal gray matter, ipsilateral normal white matter, and contralateral normal white matter. So the purpose of doing this study is to show which region, is it a gray matter or white matter in terms of the quantitative MRI signal this black line sign reside. And as we find out, this is one patient's data. The black line region is on par with all these gray matter components in terms of its T1 value, and is significantly different than the white matter components. And this finding is holds true across all the patients that we saw the black line sign. So what does this mean? It suggests that the black line region may be an abnormal gray matter component within the FCD type 2 lesion and not a subcortical U fiber, not a white matter component. In collaboration with our neuropathologist colleague, Dr. Ingvar Grunke, we looked at the well-matched pathology slide. So this is the black line sign, and I hope you can see these little arrows here that correspond to the arrows on the pathology slices. And we showed that underlying the black line region, there is accumulation of dysmorphic neurons, which is shown by the red arrow here, and balloon cells, which is shown by the yellow arrows in the black line region. So again, it supports that the black line region, there are underlying abnormal neurons and cells that are hallmark of FCD type 2B. Therefore, it is a abnormal gray matter component within the FCD 2B lesion. Outside of this one study that we performed on 70 for research, there are many other research possibilities, new MRI markers such as vascular markers, as already shown by a couple of very nice studies in the literature, improved visualization of hippocampal subfields. I didn't have time to get into that. And in fMRI, 70 is a big area with its improvement in SNR, and connectivity studies can use these improved SNR to resolve previously unseen features. Molecular imaging and X-nuclei MRI, there are many possibilities that make the 70 very exciting. So I always get this question from colleagues who are curious about our 70 experience. Which patients should not be referred to get a 70? So at this point, it's an important question because 70 is now clinical. So of course, we talked about the safety issues. If patients have RNS, BNS, which is quite common for epilepsy patients, we do not do not go to 70 for safety issues. And if patients we have very strict, very focal hypothesis in these weak spots of the brain for the patients, we do not refer them to get a 70. However, if we have a broader hypothesis that include these regions, we still refer them to get a 70 to look at these other brain areas. As I mentioned at the beginning of the talk, motion sensitivity, cooperation, we always make it clear to the patient to make the scan successful, you have to stay very still, more still than 3T. So this is also a, if you know the patient cannot stay still, probably 70 is a no-go. Okay, so take-home messages for my talk today. I hope I have shown you some interesting and encouraging data that 70 may detect previously unseen subtle FCD in almost 50% of patients with non-lesional 3T MRI. MRI post-processing, both based on 70, is essential, and it significantly increases the yield for FCD detection. For 3T lesional patients, the main pathology subgroup to benefit from 70 is periventricular nodular heterotopia and polymicrogyria. And our comparative assessment from the 7 neuroradiologist team showed that patients with focal cortical dysplasia, nodules, and polymicrogyria would most likely benefit the most from 70 due to the improved lesion conspicuity and boundary. And additional 70 findings, including novel imaging markers such as the black line sign, can potentially inform the intracranial EEG or surgical resection strategies. So with this, I would like to close my talk, and I appreciate the support from all my colleagues and appreciate your attention.
Thank you so much, Irene. This is great. Ahmed, do you want to start to ask questions?
Yes.
Oh, yeah.
Sorry, I might have gone over a little bit.
First, thank you very much, Irene. Very, very illuminating indeed. I do have a couple of questions, but I'll try to be brief. When it comes to MOGI versus FCD, I've noticed that in the images that you showed, not only do we have abnormal or differences between how those lesions look on structural 7T, but even map images look different. Is the way a lesion looks on a map helpful in determining its etiology, the pathology, maybe the surgical strategy moving forward beyond just the structural 7T?
Oh, that's a very good question. So the morphology of the finding on MAP is what you're asking.
Exactly.
So we haven't gone that far because we haven't really done a focused study to look at the morphology per se on MAP. So all the studies we have done so far is to use the MAP finding as a high Z-score region to guide the review, the radiologist review, to indicate if there's a lesion there or not. So it's mostly performed for lesion detection, but not lesion subtyping. But I think what you said is very interesting. We could look at the morphology of those maps on MAP to see if it correlates with a type 2A, type 2B, MOGI, or MMCD. So
or the resection of the MAP abnormality in itself, because I think there isn't 100% overlap between the map area and then the structural MRI area that's abnormal.
Yeah. So because everything is done sort of in parallel, right? So there could be areas that are indicated by MAP that's not included in the resection. So it would be very valuable to go back and look at a large retrospective series to see the outcome correlation.
Thank you.
Yeah, that's a great question.
Yeah, thanks, Ahmed. Thanks, Irene. A couple of questions, quick question from the audience. One is from the chat box. The duration, did you mention the duration of the scans performed on 3T and 7T? Are they similar?
Duration of the scan, yeah. So the 3T, the 7T protocol that we run with all these data is altogether about 45 minutes. So it is a little bit longer because we do stuff in the diffusion scan and sometimes the resting state MRI scan, fMRI scan at the end, as whenever the patient can tolerate. So it's a little bit longer than 3T, but not much longer for the basic structural part.
Great, thanks. The other question from the audience, I was wondering whether not only type 2 FCD can be detected, but also FCD type 1? Yeah,
that's a great question. So, and that's also $1 million question because type 2B is sort of the easier target. So let me talk a little bit about our experience per pathology. So type 2B, the big ones, they are easily seen on 3T. But 7T's main yield are the really small ones that can be missed on the 3T because it can get stuck in between the imaging slices, they don't flare, and it's hard to appreciate it on 3T. So small FCD type 2B lesions are one of the high yield area. Type 2A on 3T, in our experience, perhaps it's a half and half. That's detectable on 3T and have escape detectability on 3T. And 7T can help in the type 2A lesions. Now, the so-called type 1, we're revising in the field of FCD classification. We're revising the type 1 into the type 1A and malformation MMCD, and MOGI is one specific subtype of MMCD. And what we found is 7T was especially useful to detect MOGI, which is one type of MMCD. So this would fall into the pathology type of type 1 in the previous classification. A sort of a long answer to your question.
That's great. That's great. So next, thank you. So the next, I think we have a comment. This is not really a question, but there's from our experience in Vienna, agree with movement, weight, and the B1 in the temporal lobe as limitations. Research-wise, we'll present some more 7T MRI-SI, PWP are more interested. Finding at the next RSMRI, we're looking to glutamate, glutamine, and epileptogenicity in the future. Thank you for the comment.
Oh, this is very nice.
Yeah.
Thanks for the comment.
Thank you, Irene. I also sort of have a somewhat related question. I was wondering if you've looked at comparisons to other metabolic imaging modalities, such as FDG PET or something like that.
In between 7T and PET.
Yeah, because I certainly know in my experience with looking more at temporal lobe epilepsy that often FDG PET can be very helpful, for instance, in lateralizing. And,
yeah, exactly.
And I was wondering, if you've explored, MR spectroscopy on 7T or looked at other metabolic imaging modalities, such as PET. Right?
Yeah. Thank you, Peter, for this wonderful question. So spectroscopy, we haven't ventured into 7T spectroscopy. I think the main reason is for lack of a local expert here. It's quite complicated imaging, and it's beyond my personal bandwidth to be able to do that really well. So we haven't done that study. And for comparison with PET, I totally agree with you that with the with TLE, temporal lobe epilepsy, PET has a very important lateralization yield for TLE. But for our cohort, especially the non-lesional MRI cohort, a lot of them, the vast majority are extratemporal lobe epilepsy. And we sometimes see PET showing a very focal, like a wedge-like hypometabolic area on the PET, indicating there may be a focal lesion there. But in non-lesional cases, we usually see sort of a hypometabolic network. So the lesion is somewhat included in that network, but it's a much broader, sometimes bilateral hemispheric hypo, and sort of diffuse. So, so in our experience for extratemporal lobe epilepsy, the role of PET, especially for non-lesional MRI, is relatively low yield.
Thank you.
Yeah, thank you, Peter.
Great, thank you. One last question from the audience. It's relatively long. I guess you can read yourself, but my quick understanding is that she's probably asking when you compare two sequences between 3T and 7T, do you use exactly the same parameter, or you optimize the parameters on each field strength? And I guess this is a sort of a more general question for how fairly compare, sequences between field strengths. But what's your take on what you do?
Right. So we could not do a sequence by sequence comparison. So that is a sort of a limitation for clinical studies like this. So our comparison is, okay, we have a 3T clinical protocol that has been routinely performed on our 3T scanner, clinical scanner. And on the 7T, we used one protocol that was set after the initial phase of the technical development. Yeah, so I can't say that we are able to look at the 3D T1 weighted versus 3T versus 7T and T2 spinnacle 3T versus 7T. It was not feasible to do something like that. So we focused on the clinical yield, taking all the sequences together to come up with a clinical read, basically. Taking together all the sequences, if that helps.
Yeah, great. I totally agree with you. I do. We often get this kind of question too. It's I think it's very hard to say if you can come up with a fair comparison, right, for certain sequences between field strengths. I guess
the engineer part of me really wants to do it. But the study design, especially the clinical yield, is the ultimate question that we are asking.
Right. Yeah. What type of 3T scanner did you use? Sorry, one last question.
Okay, so it's a Skyra. We actually have a couple of them that are embedded at the Cleveland Clinic in the clinical area that the patients are routinely scanned.
Great, thanks so much. It's 15 past 12. I wish we have more time. I can go another half an hour or so, or even longer. But again, thank you so much, Irene, for this wonderful talk. And I hope we have a more chance to interact with you and discuss these interesting questions, and hopefully help with Ahmed with his study as well, and many other people. So and for the attendees, thank you so much for being here, and also thank you so much for all these comments, advices, and the questions. We'll see you next week. Next month. Thank you.
Oh, thank you so much, Jin. Thank you, Ahmad. Thank you, Peter.
Thank you so much.
Thanks, everyone. Bye-bye.